Hi, my name is Deborah Ruiz and I will speak about Zosteriform metastases from malignant melanoma. As definition, we have melanoma is a tumor that has a high tendency to metastasis to the skin. Zosteriform metastases are a rare form of metastasizing melanoma. Melanoma is a tumor that is known for its ability to metastasize to non-visceral sites such as skin, subcutaneous tissues, and regional lymph nodes in up to 42 to 57% of cases.
Melanoma accounts for only about 1% of skin cancers. However, melanoma, which means black tumor, is also the deadliest form of skin cancer. Melanoma grows very fast and can spread to the lymph nodes or internal organs. Luckily, it's highly treatable. In fact, it has a 99% cure rate when caught early. Early detection is key to determine the best treatment plan. Experts recommend using the ABCDE rule to identify the warning signs of melanoma. A. Asymmetry. Spots on your skin are normally symmetrical. If you draw a line down the middle of a mole or a skin spot, each side should look the same. However, when these two halves don't match, meaning the spot is asymmetrical, that could be signs of a problem. B. Border. Normal skin spots have a smooth, consistent border. A mole might look like a perfect circle. An abnormal skin spot might appear jagged or uneven, like a splotch or a splash. They might also have an irregular shape. C. Color. The color of a melanoma is mottled and inconsistent, with shades of brown, black, gray, red, or white mixed together. D. Diameter. Larger skin spots are a sign of skin cancer. A good rule of thumb is that a spot with a diameter bigger than a pencil eraser is abnormal and should be checked out by a doctor. E. Evolving. Normal skin spots maintain a steady appearance over time. However, if you develop a new mole or have a mole that starts to grow or change shape and texture, this could be melanoma. Doctors sometimes identify cancer using what's called the ugly duckling rule. If you have a mole that looks different from other moles nearby, perhaps it's bigger or lighter in color, that could be a warning sign. Some melanomas don't fit the ABCDE rule. Check in with your doctor if you have any sores that won't go away, unusual bumps or lesions, or changes to your skin or existing moles. Having regular skin examinations and keeping close watch for any changes just might save your life.
About the application in medicine, as a characteristic, cutaneous metastases in patients with a malignant tumor are an important clue to tumor progression or even the first manifestation of malignancy. Types of skin metastases include nodules, ulceration, inflammatory and sclerotic lesions, and a bullous or vesicular pattern. Carcinoma and cuirass and metastatic alopecia are further uncommon type of skin metastasis.
From melanocyte to melanoma. Melanocytes are cells that produce melanin, a brown-black pigment that determines the color of the skin, hair, and eyes in humans, and helps to guard against the damaging effects of the sun. In the skin, melanocytes are positioned at the epidermal-dermal junction, appearing as round cell bodies with long irregular extensions called dendrites. The formation of melanin occurs in the cell body, in an intracytoplasmic membrane-bound organelle called the melanosome. Next, the melanosome is transported by microtubules toward the surface of the melanocyte to a neighboring keratinocyte. Melanosomes are then released into the matrix of the cytoplasm in the keratinocyte and accumulate in the supranuclear region of the cytoplasm, thereby protecting the nuclei of dividing cells from the damaging effects of the sun. Several factors such as heritable predisposition and genetic mutations increase the risk of malignant melanoma. Ultraviolet UV radiation, such as that emitted by the sun, is directly absorbed by DNA and is a major risk factor for all types of skin cancer, including malignant melanoma. When UV radiation is absorbed by a double bond in a thymine base, the double bond opens, allowing the base to react with nearby molecules. If a UV-modified thymine base is adjacent to another thymine base on the same DNA strand, the two molecules can form a thymine dimer as a result of covalent bonding. The reaction most often involves the formation of two new bonds between neighboring bases, yielding a four-membered ring. The structural consequences of a UV-induced reaction include local distortions in the helix and a kinking in the DNA strand. If UV-related damage is not corrected by molecular repair mechanisms, DNA transcription and replication are blocked, and genetic information may be permanently mutated. Genetic mutations in melanocytes are associated with histologic changes along a continuum that may culminate in invasive malignancy. The transition from a normal melanocyte to metastatic melanoma may involve several histologic intermediates, including atypical dysplastic nevus of varying stages of severity, or melanoma in situ, and invasive melanoma. Indeed, melanomas diagnosed and treated during the radial growth phase have been shown to have an excellent prognosis. Currently, there is no cure for late-stage melanoma. As a result, early detection plays a critical role in reducing melanoma morbidity and mortality. New diagnostic tools to complement the visual examination of lesions, especially early-stage melanoma and borderline lesions, and those that lack the classic appearance of melanoma, could significantly enhance the detection process.
About pros and cons. As a pros, however, cutaneous metastases with a Zosteriform distribution are rare. The prevalence of Zosteriform metastases is lower than that of cutaneous melanoma localization. And as a cons, role of chemotherapy remains to be established. Several theories have been proposed to explain the mechanism of the Zosteriform distribution of metastases, even if its pathogenesis remains unknown.
Welcome to Cancer Newsline, your source for news on cancer research, diagnosis, treatment, and prevention. I'm your host, Dr. Oliver Bogler. Dr. Davies, please tell us about current therapies for melanoma. I understand that conventional chemotherapy is not always effective. So can you tell us a little bit about what's being developed?
Yeah, thank you very much, Oliver. Yeah, it's really interesting that historically melanoma has been one of the diseases where chemotherapy is really least effective. And that's really driven lots of research over the last decade to develop new, more effective therapeutic approaches. And really the treatment of melanoma has been revolutionized in the last 5 years with new targeted therapies and immune therapies. One of the challenges in the development of all these agents, though, has been the treatment of patients with melanoma that has spread to the brain or brain metastases. This is actually one of the most common complications we run into in patients with stage 4 or metastatic melanoma, where historically up to 60% of patients with metastatic melanoma have developed brain metastases. Unfortunately, many clinical trials historically have excluded patients with brain metastases, but in recent years, the investigators in the community have really transformed trials to now actually have trials specifically for patients with brain metastases. And with those trials, we're really seeing exciting results with the new therapies.
So you mentioned targeted therapies. Can you give us some examples?
Yeah, so in melanoma, approximately 50% of patients have a mutation in the BRAF gene. And so now for any patient who's diagnosed with metastatic melanoma, we do testing to see if that mutation is present. If the BRAF mutation is present, there are several targeted therapies, which are pills that patients take once or twice a day, which are very effective at attacking the cancer cells. Those treatments actually can cause reduction in tumor size in up to 70 to 80% of patients that have the BRAF mutation. Unfortunately, they don't work for patients that don't have the BRAF mutation. One of the exciting things we found is that these treatments can be very effective even when melanoma has spread to the brain.
Is testing for that BRAF mutation you mentioned routine?
So testing for that mutation is absolutely routine for patients with metastatic melanoma, and due to an increasing number of clinical trials for patients with earlier stage disease, we're starting to see testing for that mutation done in more and more patients every day.
Now, there's been a lot of excitement in some cancers with new immunotherapies where the immune system is activated. Is there anything for melanoma in that area?
Absolutely. And again, historically, because this cancer didn't respond to chemotherapy, this was one of the earliest diseases in which we really investigated immune therapy as a new strategy to control cancer. Again, what this approach takes advantage of is the fact that we all have an immune system that's designed to defend our body against foreign invaders or other problems, particularly infections. But it appears that the immune system is also there to battle cancer. The question has been, why does that defense system break down in patients with cancer? And more importantly, how can we reinvigorate the immune system to recognize and attack the disease? And melanoma has really been at the leading edge of immunotherapy research. Indeed, one of the very first treatments that was approved for melanoma in the 1990s was high-dose interleukin-2, an immune therapy that stimulates the immune system and results in cures in approximately 5% of patients with metastatic melanoma. However, it's actually one of the most dangerous therapies that we give and has to be given in an intensive care unit setting. However, what we've seen over the last few years are new checkpoint inhibitor immune therapies, which are given as IV treatments on an outpatient basis every 2 to 3 weeks, which actually appear to be achieving durable disease control in anywhere from 30 to even 50% of patients with metastatic melanoma. That being said, immune therapy for brain metastases is quite challenging because the way that immune therapy works is by causing the immune system to attack the cancer cells, which causes inflammation. In many parts of the body, that doesn't cause problems, but actually an inflamed tumor can actually cause side effects if that tumor is in the brain.
Lastly, talking about a more sort of old standby therapy, radiation therapy, which has been around a long time, I understand there have also been some advances in this regard for melanoma patients with brain mets. Is that true?
Absolutely. So historically, the way that we used to treat patients with brain metastases was whole brain radiation therapy. This was a way to provide radiation to the tumor cells, but actually had as a downside that it would radiate the normal brain tissue as well. Over the years, we've developed much more sophisticated ways of providing radiation through focused approaches that really aim high-intensity radiation at the tumors without doing damage to the normal brain, and so-called stereotactic radiation surgery, or here at MD Anderson, what we call the gamma knife treatment. And this therapy is very effective at controlling the brain metastases. We're actually now really interested in exploring whether that therapeutic treatment can be combined with the targeted therapies and the immune therapies to improve patients in patients with brain metastases from melanoma.
Dr. Davies, thank you very much for sharing your knowledge with our listeners.
Thank you very much. It was my pleasure.
For more information, visit mdanderson.org. Thank you for listening to Cancer Newsline. Tune in for the next episode in our series.
About issues applied in Ecuador being a country whose population is predominantly mestizo, it occupies the rank 40 in relation to diagnosis of melanoma. Well, below country where white ethnicity predominates, however, 1 in 136 deaths in 2008 is due to melanoma in the city of Quito. In addition, the incidence of malignant melanoma in the city represents 10.1% of all pathologies malignant skin. On the other hand, according to the incidence rate of cancer incident in 5 continents, Cuenca is ranked 123 for men and 140 for women. In this city, melanoma represents 2.2% of all of cancers in men and 1.1% in women with relative risks of men to women. And we have Zosteriform metastases, a rare form to metastasine melanoma. There are several theories that try to explain this rare melanoma dissemination, but none is proved. Thank you.